Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only. All right, everyone, welcome to another episode of the
Life of Flow
podcast. And today we had probably one of our best interviews ever, I would say.
hands down.
Anthony, or Dr. Back, is a board-certified physician at colorectal services at the University of Washington Medical Center, co-director for the University of Washington Center for Excellence in Palliative Care, and a University of Washington professor of oncology and medicine and adjunct professor of bioethics and humanities.
So he's legit.
So this guy's like
Legit.
done more than both of those combined in academics.
In everything.
In everything.
In
Yeah.
self-solution,
He's a sen.
meditation,
There's been
in clinical work.
Yeah.
We are plumbers.
We are plumbers. So
We are plumbers. Bum, ba-dum, bum, 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 bum.
Jesus. So Anthony has some really interesting research around the use of psilocybin and physician burnout. And we dove deep. We had some really interesting conversations. We had a whole
So
letting go of some COVID frustrations that we had. So it was really cool. I really enjoyed it. We're definitely having him back, and I hope you guys enjoyed the show.
stick around.
All right, everyone. Anthony, thank you for being here. Appreciate it. I appreciate your time on a Saturday morning. I think you're in Washington State, right?
Correct.
So that you're
Thank you for having me.
Yeah.
This is exciting. I'm excited.
Yeah, I'm excited. This is a super interesting, timely. It kind of ties into a lot of the conversations we've had before. So how about
Well, as vascular surgeons and having, primarily our audience being people related to vascular care or people in the industry of vascular care, one of the things that we deal with is chronic limb-threatening ischemia, which unfortunately, this peripheral arterial disease-based thing with diabetes and chronic kidney failure and all these things are ultimately incurable. You can treat, you can palliate, and I always say that, vascular surgeons, we're the champions of palliative surgery of the blood flow. But these people go through a lot. It's a very long road. It's one that's potentially full with hiccups, stents going down, bypasses going down, being back in the hospital, new procedures, new amputations, 1 toe, 2 toes, 3 toes below the knee. And we see that on a firsthand how these patients really have a hard time with some of these chronic conditions. And then obviously here we talk a lot about what that stress means for us, dealing with chronically ill patients, severely ill patients, how those conversations go, how to set expectations. And anyway, it just feels like having somebody of your caliber and with your background is going to fit perfectly in for our audience and certainly for us in a very selfish way, because we call this Life of Flow podcast as our little therapy session. It's free therapy. We get to talk to the coolest people in the world for an hour.
Yeah.
And we don't pay you. So
Wait a minute. Now you're telling me.
but anyway, all that to say, thank you, man. This is fun. This is good and very, very enticing.
Yeah, so if you wouldn't mind giving our audience a little bit of background and how your
how'd you
journey
get
started.
to do this?
Yeah.
It's not, doesn't seem like something you wake up one day and say, this is what I'm going to do. But I'd love to know your
It
path.
totally was not. I mean, I'll give you my little medical biography just so, just to know that. So I went to Stanford University while I was an undergraduate. My mother died of a blood cancer when I was a sophomore. And so that really pushed me into actually doing a humanities major, one of those do-it-yourself majors, because I felt like I just needed to figure out how to live, honestly. She had been ill for some years before she died. And then I went to Harvard Medical School and went into medical oncology and realized I was not really an East Coast kind of person and came back to the West Coast. And so I've been at the university ever since. but for a bunch of different phases in my career. And the way I got to this work, meaning the work in psychedelics, is kind of a long and winding kind of thing. I realized as a young oncologist that I was being exposed to a tremendous amount of human suffering, just like a lot. Like you were just mentioning, the kinds of things you guys deal with as vascular surgeons, people with a chronic progressive condition with ups and downs, a lot of trust in the physicians about whether or not something is going to work, risky procedures, outcomes that are sometimes great and sometimes terrible, and a lot of, loss of function. And all that really, in many ways, comes to the doctor and the medical team. And I felt like as a medical student, as a physician, I really didn't have any mentoring about how to handle all that. I didn't really have role models about how to handle that. And I was kind of like, whoa, what am I supposed to do with all this? And that led me to seek out some other kinds of mentors that were outside actually the regular kind of academic medicine world I lived in, because, what I saw was in my academic world was senior physicians who gradually distance themselves in different ways. They distance themselves from the patients, they distance themselves from the suffering. They certainly distanced themselves from my suffering. And I thought it was not supportive, actually. And, the culture of academic medicine and, medicine in general is quite hierarchical, and the education is kind of based on shame and humiliation, as well as a lot of memorization. And anyway, all that meant for a very tough time, honestly. And so I found a couple of mentors who were really physicians outside the system. One of them was Rachel Remen at Commonweal, who used to do retreats for physicians only, which was where I really felt like I discovered my voice as a physician and my vocation of healing, honestly. I kind of thought I had it in medical school, and it was kind of diluted out of me by, my training. I went to medical school when the surgery rotation was every other night call. And, it was brutal. It was brutal and brutalizing. And I actually just thought I can't even survive. I could barely even survive the 2 months of it, much less a whole career. So I have my hats off to you guys, because I think that, what you guys do is a very demanding thing technically, but also quite demanding emotionally.
Anthony, do you know what the reward was? Well, we, as a medical student, we did every other night call. And do you know what the reward was for being overnight on call as a medical student? The reward was to operate the next day with the chief all day, just holding a retractor. That was your reward for being all night on call. So you were 48 hours, 36 hours awake. And then you were like supposed to be grateful for that shit. That was crazy.
Right. I remember that, holding the retractor. And I actually remember other medical students who kind of fell asleep while they were holding the retractor and then were totally reamed, honestly. I was not that good. I didn't hold the retractor that many times, but it was pretty obvious. And then the other thing I really remember from my surgery rotation was that there was a little breakfast place, coffee shop that was on the next block from the hospital. This was Mass General in Boston. And they had a house phone. This was, of course, before, like cell phones. And on Sunday mornings, the whole team would go there in the morning for breakfast. And then their wives would bring in their kids for their weekly visit.
Oh my God.
And the whole thing kind of blew me away. I was just like,
that's so sad.
But I'm just saying all this because it sets the stage for, it's the craziest thing, but it sets the stage for what it meant to be a physician and what it meant to take care of yourself, so that you could actually do your best work, right? Like that, so that you could deal with the combined emotional and technical challenges that are coming at you in very short order, right? So fast forward a bit. The other thing that I really discovered from another mentor was meditation. And I found that really learning to know myself in that way has been extremely valuable. So at this point, I've been a Zen practitioner for 30 years. And it is the thing that I really return to. And it is the bedrock. Like, I still sit every day. And that part of, for me, and I realize it's not for everybody, but for me, it has been a kind of daily recalibration of, where I am and getting ready to what I'm doing in the world that day. That said, in the mid 2010s, around 2015, I was doing some work about research in end-of-life care, and met a foundation guy who was, it turns out, the foundation, one of the foundations that was funding early work in psychedelics at Hopkins. And so he talked to me about what they were doing with cancer patients. And I was like, wow, what is this? And I couldn't tell, honestly, whether it was just crazy talk or whether there was really something to it. But then he said there were these other studies, and I read the papers about cancer patients that got published and some of the other literature. And I thought, wow, maybe there really is something to this. In college and medical school, I was kind of a nerd, and I had never done any kind of, psychedelic anything. Like, I hadn't even smoked pot because I was too scared, honestly. And so I arranged for myself in about 2018, a year or two after the big cancer papers came out, to have a guided trip. So I found a psychologist who was like a regular practitioner who was also doing this underground work. And I had an underground trip that was set up the same way the research studies are set up. A couple of prep sessions that are psychotherapy, then the medicine day, which is kind of all day long, and then the integration sessions. And I had a really profound experience. I had done a lot of introspection and a lot of work and, lots of meditation, right, by that point. And even then I thought, whoa, there is a part of me that I hadn't really touched. There was a sense in which I was, interconnected to the people I was with and to like everything in the world. And there was this sense of energy flowing through me that I had really never consciously really perceived before. And it really upended my whole worldview of, whether or not we live in just a material universe. So then I thought, I'm going to pursue this. I went to the California Institute of Integral Studies that had the first training program for psychedelic therapists to try to figure out and understand more about what was going on. Heard a bunch of the early researchers in the field talk about what they were doing and how they had, adapted these practices from underground practitioners who learned them from indigenous practitioners, and then got some funding. And the first study, which happened right at the end of the bad COVID part, was this study of psilocybin for doctors and nurses with depression and burnout from their work in the pandemic. I've done some other work in clinician wellness around the pandemic as kind of an offshoot of my other work. And so, for example, I've been a leader, one of the retreat leaders for a yearly retreat at Upaya Zen Center in Santa Fe. That's where my Zen teacher is, Roshi Joan Halifax. And we do a week-long retreat that is a deep dive for doctors and nurses. And I've been doing that for 20 years, right? But I could see in COVID that we were really facing something, totally different, right? I remember, Seattle was where the first cases were. I don't know if you remember, but the nursing home where the first case of COVID was discovered was right outside Seattle. And I remember being on a phone call with like 250 doctors, trying to figure out what the hell to do with all these patients, right? They were talking about cases and trying to figure out, what to do with their ventilators and stuff. And then somebody happened to mention that one of the ICU doctors, a senior ICU physician who was a revered person in town, was intubated and had gotten COVID. And there was just a moment of dead silence, and everyone went, oh shit, So that was this moment of
we all
extreme
had that. Do you remember
vulnerability.
that during this?
Yeah,
I remember one of the chief of cardiac surgery and cardiology at my hospital when he got admitted and intubated, and we were like, fuck.
Well, I had
This is, because there's this sense of, at the beginning, there's obviously, we don't understand what's going on. Then, okay, well, there's this massive thing coming, and they're coming in every direction. And for us, remember, they got prothrombotic. So my first thing was,
Yes.
why are all these
right.
bypasses occluting? I remember like declotting
Right.
bypasses left and right. I was like, this is so weird. Like, why are people...
aortas having de novo thrombosis of the aorta?
No, it was just something that,
Ooh.
just very, very odd. But to your point, I remember I remember operating this patient had COVID, and one of the central lines, massive hemodialysis line, had come out, an ECMO, an extracorporeal membrane oxygenation. So big ass tube in the groin in the ICU, and the thing came out. And this is like the beginning. And I remember Zach's a colleague of mine. They were together when they were doing their fellowship. I said, Zach, I'm going to go and operate on this. I have no idea what this virus is, but this guy's dying and we got to go in, and it is what it is. You can stay outside. And I remember him saying like, no, we're in, let's go. We were in there they didn't want to move the patient to the OR. The guy's bleeding in the floor, and everybody was psychotic about, well, what if we're going to put viruses all over the world? Like this whole thing.
Right.
And I remember we went in there with iPhone flashlights, and I am stitching. I am not joking. There were 3 nurses with iPhone cameras, and we were just stitching and doing shit there. And I mean, look, my hair's just getting crazy because I remember how like it was just out of this world. And still then, it didn't feel home until they say Dr. X, a very renowned doctor, he's in room 4 and he's intubated. And I was like, this is coming for us.
Yeah, no,
like we're in this.
So Bernardino, when Bernardino told me, and it was coming, and we knew it's coming. Bernardino told me one of his medical his medical school colleagues had died, our age, in Brazil. And then I thought the same thing that Zach said. I'm like, because there was a lot of conversation, a lot of people were like, because it was like all hands on deck, everyone, even if you're a dermatologist, you have to be in the ICU. And there were people that said, I didn't sign up for this. I'm not going to do that. And I was like, I signed up for it. I'm going to do it. But then I actually contemplated dying with this. And I actually went to the Texas Hill Country for a weekend just to like really center myself and just say, I could die. There's a high chance that I could die. And we had a patient that had thrombosis of the popliteal artery. And we're there like all the freaking masks operating. And then the medical student, who is a vascular surgeon now, I'm not going to say his name, but you know who he is. He released the clamp in the wrong order, sprayed me in the face with COVID blood, bro. Full blown, like this patient was like sick as hell. And then I just said, if you kill your attending, you fail the rotation, right?
So wrong.
Yeah. So yeah, I contemplated dying.
I digress, but I'm saying how big how impactful it was, and we're still paying the bill for that, man. There are people.
We're still in this post-COVID. As a palliative care doctor, it's this kind of complicated grief thing that's going on, and there were a number of people in my study who said, well, everybody says you should get over it. It's over. And they would say, but it's not over for me, right? Because those moments of extreme vulnerability, right? No one forgets those. But then when that is compounded by other issues, right? And then the other issues were like the institution actually didn't help you get the resources you needed to protect yourself and to practice with some modicum of safety, right? When the patient started to accuse you of faking test results so that you would make money and the hospital would make money, when they started to throw bedpans at you and spit in your face because they were so angry, when family members were bringing guns into the ICU, I mean, that was when a lot of clinicians who had said before, actually, I'm in on this, said to themselves, wait a minute, why am I doing this?
Yeah.
Right? I mean, this deep disillusionment,
And
not to mention
I'm sorry,
just
but
physical
rightfully
exhaustion
so.
and grief.
Rightfully
right?
so. I can't blame anybody for
Absolutely.
saying, fuck this.
I mean,
why do I have to be, a gun? You're coming at me. And I'm using my mask for the 5th day in a row. Remember, we couldn't even throw our fucking masks off. We had to reuse them day
This
after
was
day,
the stupidest
and
fucking
then
thing
go
on
and
planet
sign
Earth.
in
Yeah.
to get a new mask from some dumb administrative person that will look at you in disdain because they look at it and be like,
Right.
it looks like you could still pull a day off of that.
Yeah.
You give me a fucking new mask
oh my
right now.
God.
Yeah.
I'm sorry, but
You're
it was
kidding
really
me.
tough.
Yeah.
Right. I know.
Tough stuff.
And it was really, I mean, it was actually a deep breakdown in the culture of medicine, right?
Yeah.
Like it's and we're still paying for it.
Yeah.
Oh, and we will for a while, I think. I think this is
it's
a
changed us,
wound.
honestly.
Yeah.
I
This
think
is a
as a
wound.
culture, I think it's changed us as a culture. I think it's really changed the level of trust that physicians and other clinicians have in their institutions and the leaders and in the big systems that are, part of the health of the public, right? And of course, this is, a big topic right now. But the COVID was a very important kind of beginning, and it's been very disillusioning.
So
people.
I'm very curious because it sounds to me like, I mean, sometimes when I was still in my academic years, trying to push something through the IRB was like pulling teeth. And you had all these people coming at you, giving you all this. Can you walk me through what the process was to get a study approved to use a substance that in a way was still illegal in some states, illegal federally?
Oh, it's illegal federally. It's illegal
exactly.
everywhere, right?
And you're not only saying, hey, I want to use this on healthcare providers within an institution.
An academic institution?
Yeah,
That's
that just
crazy.
sounds like
Yeah.
a mountain. You moved a mountain. How did that work out?
Well, yeah, I know. Just to echo what you're saying, I mean, the chief medical officer of the university hospital at the time heard about this study and said, should we let these people come back to work? And so that was when I realized I needed a certificate of confidentiality. So the process is, just in brief,
please, because this is super interesting.
The funding. Yeah. You get the funding. You write the detailed protocol. You send it to the FDA. The FDA approves it. Then you send it to your scientific review committee at your university. Then you send it to the IRB. Then the IRB asks you, all these things. Then you implement the study. And of course, I had to get a DEA Schedule 1 license. You have to have the special medical license to handle and dispense psilocybin because it is still a Schedule 1 medicine that is felt to have no human benefit.
Mm-hmm.
And actually I had to dispense it all because the institution that I'm in did not have a Schedule 1 license for humans. It turns out this was the first Schedule 1 study in humans at the University of Washington and even in Washington State. So I had to get all, there was a lot of
How funny
regulatory
is
stuff
that?
involved.
And then you dispense like oxy, like it's candy, right?
Totally.
How funny and ironic is that, right? Anyways.
It's very,
Funny, depressing.
It's a state of where we are right now. Well, many people would say that, many people in the psychedelic ecosystem would say, this is the legacy of basically an older culture war where Nixon was declaring war on the hippies, right? They were declaring war on the blacks and the hippies. And so the way they did it for the hippies was to criminalize psychedelics, right? And that's never been changed. And so we're still dealing with all of the regs for that. But it is a huge slowdown and a huge expense for people who want to use these medicines for healing in other realms. So yeah, it's not a very interesting story, but there is a lot of paperwork you have to do. Now, I had done a bunch of clinical trials before, so I kind of knew the drill. And the other thing that was, I think, helped in my favor was that the IRB and the scientific committee, they knew me, right? They knew I wasn't some wacko who's trying to come in and do some wacky things. And that was where being like a person who had been around in the system really did help me.
Yeah, it's something, probably just a senior academician can pull off, because, some young buck comes in with something, he's going to be shut down immediately. Yeah.
I mean, at that point, you're probably right. I mean, they probably would have asked a million more questions about, what are you doing, et cetera, et cetera.
So what did you find?
Well, first of all, what inspired you to do it? Like, when did you get the idea?
Yeah. What inspired me was, just in my wearing my palliative care hat and knowing how much the people with cancer had benefited, because of their extreme brush with mortality. I thought, well, a version of that is happening to the clinicians that I work with right now. There is this extreme vulnerability. There's this extreme exposure to death. There is this huge uncertainty about am I even doing the right thing? And there were a lot of clinicians who had big regrets about things that they could have done differently or didn't think to do. Clinicians are, a lot of doctors are perfectionists, and they were just torturing themselves with, whoa, coulda, woulda, shoulda kinds of stuff. And that made me think, well, if psilocybin can change the way that people with cancer approach their own mortality, maybe psilocybin could change the way that doctors approach their own vulnerability and their own experiences with suffering. So that was the inspiration.
Yeah, I actually have a story that's what kind of fucks with your brain, is not the thing that you did that was wrong, is the thing that you didn't do. Because I remember being in the ICU as a resident, and something happened to a patient that was intubated. And there was a brief moment in my mind where I thought, I should bronch this guy and do a lavage. And something said, oh, probably, maybe not. So I didn't do it, because at that moment, like the pros and balances, I weighed them against doing it. Because it was a pretty sick individual. And then he died in the morning of just basically a plug. I had an arrest. And I knew that the thought had been in my mind that I should have done it. And I cried all the way from the parking lot to my house. Because I'm like,
yeah,
fuck. That's when I was like, oh, fuck, this is heavy. Like, it's not only what you do. I can deal with, like, if I made a decision and it was the wrong decision, but to not make a decision, which is also to make a decision, that's more difficult. Yeah.
And it's part of what it is that we do, and part of our profession, that there are these moments, and they're really hard moments. And I think at least when I was getting trained, I think maybe things are a little bit different now, but when I was getting trained, there would be these M&M kinds of conferences, and people would basically just rub your face in your mistake, right, in a brutal, humiliating way. And the kind of subtext of that is, if you're not perfect, you're going to be publicly dressed down, right? Everyone's going to be talking about your mistake. It's going to be pointed out in public in the meanest possible way, and you'll be hung out to dry. And I think that I think at least my generation of physicians had all internalized a certain amount of that. And, maybe in earlier days, it was part of, a healthy drive to improve. But that perfectionism thing, and that second guessing yourself and the shaming yourself, that can really turn into a thought loop that is punishing and actually counterproductive, right? And can be the kind of ruminative thought loop that turns into something that leads to burnout and then to depression, right? And so, and that kind of thought loop is actually what psilocybin can disrupt, right? I mean, and so that is one of the beauties of this kind of psychedelic work.
So we have a running hypothesis as to how it unleashes us, how it kind of resets us, or it helps. Is that?
Yeah. What's your tell me your hypothesis, and I'll tell you my version of it.
Oh shit! No, mine's probably super uneducated. Which is, it's an absolute reset. Um, what you mentioned before, I feel that was resonated with me, which is the moment you're in there, you realize that everything is alive, that all these molecules are alive, and that you're part of a bigger thing that's hard to explain. And when that happens, and that flow of energy, and you can look at it and you see the energy moving in and out, and the colors and the trees and the things and all these things, was very balancing, was very humbling. Was, you come down as you integrate and you say, I am nothing, right? I am nothing, but I am everything. And I think that is a very liberating moment. That kind of got you out of the pettiness of your own existence and your own
That's right.
constructions. But I don't have, for sure, that's just an experience-based thing, not that I have a hypothesis of the neurotransmitters or anything that happens.
Well, it is, I mean, just to back up from that, though, because I think in a way that's a beautiful illustration of how psychedelics can work in the best case scenario, is that, that sense of there's actually much more to me than just my little self and my one little brain and my one little practice. And actually, I'm part of this much bigger flow of everything. And then the way that drills down to these ruminative thought loops is, we all have habits of mind that, one of the scientists I know likens to skiing down a ski slope where there are a lot of moguls, right? And you kind of know the slope and you know the moguls, and you tend to take the same kind of route down the slope, right? Which is, you tend to think, oh, I should have done that. I'm no good. I really need to do blah, 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 right? And over time, those habits of thought can get really hardened, like really deep grooves in the moguls, so that actually there is not the possibility of skiing another route down the mountain. You have to ski in that route down the mountain, and you end up having to think these things like, maybe I'm just not good enough. Maybe the problem is me. Maybe my patients don't do well because of me, right? Maybe I'm just not worthwhile, right? And what the psychedelics can do, the psilocybin in particular is binding to your serotonin receptors and giving you a kind of reset that reduces temporarily all the activity in the part of your brain that creates the self, that creates the little me that acts in the world like this, that has these kinds of thoughts, that has this kind of background, right? And by disrupting that sense of self, it kind of opens you up to see all this other stuff and feel all this other stuff. And much of it is about feelings, not necessarily about thoughts. And being released from those habits of mind can make you realize, whoa, this is bigger. This COVID thing is bigger than just my not starting the proning early enough, or not, whatever it is, like whatever your intervention is, whatever your expertise is, this is much bigger than my expertise. And then as a human, just one human in the whole scenario of this, there is still a lot I can do, and a lot I can do if I take care of myself in a certain way. And I am just a human with my own limitations and my own need for renewal and my own need to be loved. And actually, I need to respect all that and honor it and do that stuff. And then I will be able to come to work and actually be the kind of doctor that I know I can be, right? That I want to be. And so that's kind of the qualitative sense of what can happen with a psilocybin kind of guided experience like this.
Is there
Should we talk about the
is there a
study?
metaphysical
I want to know what the study.
I want to a question. Is there a metaphysical?
I'll show you this. Yeah, I can show you the study. But what's your
Yeah.
question, Lucas?
Is there a metaphysical component to this? Is there,
Yeah.
and
Yeah,
like
yeah.
how do we
Well,
reconcile that as, physician, scientists, to bring those two together and have them coexist?
Yeah.
It's kind of like living in paradox, no?
Totally, it is. I mean, I think it's one of the challenges for us as physicians and for the field of psychedelics right now is how do we reconcile this, right? Because there is a psychological level at which many of these studies are being, measured, and the kinds of measures I'm going to show you are basically psychological measures. But as you can see from your stories and my stories, that it is kind of about a metaphysical experience, right? Carl Jung talked about how his own approach wasn't about just getting rid of neurosis. It was really about creating what he called an approach to the numinous, approach to the tremendous, awesome mystery that is, existence and the universe. And that being tuned into that, in fact, was the real source of healing and the real source of being, as he put it, released from pathology. So I'm going to show you like psychological endpoints, and those are the ones that I can get published in a journal, because all anyone cares about in the journals is, do I have a number that went up or down?
Yeah.
Right?
And
but
is there
really
a p-value
the stories,
to it? Yeah.
Yeah, and a p-value,
Yeah.
right? I got and
Yeah.
I
Make
right,
sure
I've
that
got the p-value
p-value's
too.
there. Yeah.
Exactly. But really, the experience of having these psychedelic experience, it's totally different. And in fact, when I do my new studies now with cancer patients, one of the things I have to do is like give them other ways to think about their own experiences of suffering besides, have you rated it on a 1 to 10 scale? Have you filled out that distress thermometer? Have you rated your every depression symptom on a 1 to 5 scale? Right? It turns out those scales don't really help you process things very well. Right? So they're psychometrically good, but they're not actually personally useful. But I can tell you that maybe I can even show. Can I even show you that? I can show you
can
the
share screen.
Results.
Yeah.
Okay. Can you see this?
Oh, beautiful.
So, okay. So can you see my graph here?
Yeah.
Mm-hmm.
Yeah. Okay. So these blue lines represent, every one of these blue lines represents one of the people who was randomized to the placebo, which is niacin. And you can see that their depression scores, which are here on the left, and go from 0 up to, it can go up to 60. You can see that most of them are kind of flat. So this is before they start, right at the baseline. And this last point is day 28, after their medicine day, which was for them niacin, right? There are a couple of people who went down quite a bit with just therapy, but most of the people were kind of flat, right? If you look at the people in the psilocybin arm, they got the same preparation visits. They got 25 milligrams of psilocybin. You can see the slope of their scores is much greater, right? For almost all of them.
Was
right?
it
They
a
all had
daily
a drop.
dose? Daily dose for how long?
No, it was one single dose. It was one single dose with a journey that was like an all day. It's like a 6-hour thing. So this is 2 therapy sessions, a day of medicine, and then 3 more therapy sessions, and that was it from start to finish. Right?
So just one intervention caused that massive change.
One intervention caused this. And if you look at the change scores here, you can see on these, bar and whisker graphs.
Yeah.
The blue bar is the placebo, the yellow bar is the psilocybin, and the difference, the p-value for this comparison was 0.0002. Right?
Yeah.
In the paper, it's actually just less than 0.001 because that's the convention of the paper. They don't let you report p-values that are smaller than that, but the actual p-value is 0.002.
I mean, you can see it just visually. It's clear as day.
Yeah, you can see it. It's really obvious, right? And then you can also see what happened at the 6, if you follow people for 6 months. Here you can see the people who originally got assigned to psilocybin, they went down. And at 6 months, everybody was still down except one person. And then the people who got niacin were then eligible to get open label psilocybin, because we thought it wouldn't be fair. And I didn't think people would enroll in the study, honestly, if they didn't all have the chance to have psilocybin. And
Yeah.
you can see there was one person who went up. The rest of the people were much lower and pretty stable. So at least in this small study, these were 30 clinicians who were randomized to either psilocybin or niacin at the beginning. There's some durability to this, right? So those are the main results.
Is there a qualitative assessment that won't fit in a paper about people refinding purpose as a physician? Because I think I think purpose is very important. And when we start medical school, we're full of purpose, and we're in residency, we're full of purpose, and we're starting our job, we're full of purpose. And then the constant emails about charts, that kills me. That decreases my fucking drive like a lot.
Totally. Well, so I can read you some illustrative quotes here. So before the study at the beginning, here are a couple of quotes. This was an emergency room person. I feel more disposable than a used COVID swab. And another person said, I think this was a nurse, it got to the point where I felt I was participating in the torture of people. And then afterwards, here's one. I'm reaching out and leaning on others and trusting that the people around me can support me. I don't have to carry it all by myself. And another one was, I was shown my tendency to be a superhero, and got messaging that, quote, it's not about you, done in a way with grace, love, and accountability. And so you could see that there was a big, those comments, I think, symbolize that reorientation. And then I think the other part that you are getting to about recovering purpose is that, if we tracked the people and big job changes that they made, we actually told them, we recommended not to make a big job change for at least a month after your trip, right? So you don't do something rashly. But over time, in the time that we followed people, like 70% of them changed their jobs within medicine. Wow. It was interesting. Nobody left medical care, but a large majority changed what they were doing. And they left positions that they felt were not sustainable. They refocused their careers on things that they felt like really would give them purpose. And in some ways, they kind of woke up to their own purpose and thought, like, what should I be doing to really follow this pathway for myself?
That's super interesting. So how is this at all controversial?
So much to process.
When
so amazing.
How is this viewed in this space that people doing this research? Because it seems like just visually, it'll be hard to argue that you had an effect, and it'll be hard to argue that effect is not significant. So how? What is the argument right now? What's the discussion?
It's kind of interesting. Well, so in the psychedelic ecosystem, they're like, yeah, this is great. Another demonstration that psilocybin is really valuable. In the medical world, in the world of health systems, I haven't heard that much from people. I thought I would actually hear more. But within the world of health systems, there's been quite a lot of attention paid to clinician wellness. But this is different than what the general view is out there, because the general view is that 80% of the problem in clinician well-being is a system problem. And so the systems need to be fixed. And I think this is upending that, because it's saying that, the way an individual clinician views and deals with their situation is a huge factor, right? And to me, that's always been the underestimated piece of, what it means to have well-being as a physician in these complicated systems. And so interestingly, even though it's totally counter to the prevailing wisdom, and maybe because of that, I have not heard much from people who do systems. I'm really good friends with one of the real leaders in this well-being area, and he was like, wow, and this is really amazing. And no one has asked me to talk at a well-being conference. So Here we are. You're the
Yeah.
first part. You're the first medical podcast I've been on even.
Oh,
Wow.
there you go.
Well, I'll tell you what I think. I think that people are afraid. I mean, yesterday you and I were talking about this. Lucas and I were talking about how, unfortunately, if this continues to grow, and it does continue to show that it's a very disruptive, very positive, therapy, who are going to be the last ones to actually be able to get to it? It's going to be us, because with the amount of medical, legal tape and how these institutions work. I mean, look at what you mentioned briefly before, that somebody within the C-suite said, "Are these people able to come back to work?"
To work.
To work.
Yeah.
Right.
That is the exact, and that's a problem, because
Exactly.
how unfair.
They can take Xanax at night to for
No, they
anxiety.
can
but
take
but yeah.
Xanax. Listen, they can
Right.
take
Xanax, no problem.
They can
Right.
take methamphetamines and
Yeah.
come to work.
Yeah.
Right?
Work.
You could be juiced, or you could be downed, or you could be doped, and that's totally fine.
Yeah.
Totally okay
Yeah.
to let you go on, put somebody under the knife.
Yeah.
But if you get one single trip of something that's out there that's, because of the legality of it,
Yeah.
I think we're going to be the last ones to get the benefit of this. It's going to be far and beyond.
You're probably right. I mean, people were scared, and so I had gotten this FDA certificate of confidentiality, which means that in my study, there really is no chance that there's
Nobody
very little
know.
chance that the name could know. Right. Because even if I were to be sued by a health system to find out if somebody participated, I would not have to provide their name. Right. And then actually, because of all this crazy stuff about in some states, physicians have to report whether they had received mental health care or not, right? And it's publicly discoverable. What we developed for this study, the reason this is studies for symptoms of depression, is because we did not diagnose anyone with depression intentionally. All we did was measure symptoms of depression. And so that's why this study is about symptoms of depression. And we told them, you have participated in a clinical trial, that is not mental health therapy. So you don't have anything to report.
Yeah. Yeah, it's really there is such a constraint around, or we feel like, we were talking about this yesterday. We were talking about where are we willing to go and where we're willing to not go on this podcast. And it's a struggle because we both have to work. We both have to have a medical license. We have to provide. Miguel has a brand new business, so we were actually having that discussions, where can we go? What are the risks? Is a medical board going to come after us for just having a discussion about data, or having a discussion about something that's a really interesting and burgeoning field that has a ton of potential? Because I immediately, and we were talking about that, we did, when I do an amputation of one of my patients, I can see the trauma I caused. I didn't cause it, but I cut off the leg, so I feel partly responsible.
It's a big deal.
And I did a bunch of procedures to try to save that leg, and I failed. So there's a ton of responsibility. And then, we go through it, we take the final sutures, and then you're like, okay, off on your way, good luck. See you when you have a problem with the other leg. And there is such a big gap. There's such a big gap that needs to be filled to really treat these patients. And I think that goes back to the distrust people are feeling with us, because they feel it's all transactional. They feel like you come in, you do a surgery, you get money from that, and then you send them off their way to fend for themselves with all this that happened. And then there is, if you really don't connect with the patient, there's a resentment for it. They feel like they've been used. And I feel like it's not that this is the answer to every single problem, or to this particular problem, but I think it could be a way in which we extend help to these patients, and then to physicians that are burned out. Like, we talk to a lot of physicians that are burned out, that have lost a purpose in something that's so beautiful, like to like that performing surgery in someone is one of the most intimate things. It's one of the most intimate relationships.
So much trust required, right?
And it's really beautiful.
Yeah.
But like, to the fact that so many people lose that is sad. It's really sad.
Yeah. Yeah. No, I've been thinking about what to do with the next study, and my next study I think is really going to be symptoms of depression plus loss of purpose, right? Because I think that's where these medicines really have a role.
That's true. Well, listen, I was just gonna say, man, I commend you for doing this. You are a hero amongst us. You are a voice.
Thank you.
You're a voice for the unheard. Of all these sad stories that happen across America.
You're brave. You're really brave.
And for anybody out there that's considering, learn more, remove your biases, open your mind, understand that there are other things out there. Throw the opiate prescription pads away, and hope that there's a future where we could be adding a little bit more, more color.
Yeah. You know? And can I just add one thing, that this is not a do-it-yourself kind of thing, right? Your listeners are physicians, and they're super smart and super capable people, and yet this is a kind of thing you really need somebody with you,
guidance,
right? Yeah.
Let me just a very quick story on somebody I knew. They had some mental history and went on a big trip to Mexico for psychedelics, and it was all for more recreational purpose. And this person had a very tough time reintegrating, huge, to the point that there was inpatient rehab and a bunch of other things that happened. So I do believe that it has to be viewed with a significant responsibility. It is something that you need guidance. It is something, especially if you're dealing, the heavier the demons, the more the hand holding, as the power and the energy of the world reveals to yourself. But coming back and reintegrating is a very, very crucial part of this. Not to scare people, but just to support the fact that you're saying, this is something that you want to do right?
Yeah, absolutely. And one of the things about that I didn't mention already is that in our teams of therapists, we always had somebody who was matched with the profession of the person. So if there was a doctor who was the participant, we always had a doctor as one of the study therapists. If there was a nurse, we always had a nurse as one of the study, et cetera, et cetera. And the reason is because of that, shared knowledge of what you're up against in the professional world, and then also this help in how are you going to walk back into your workplace with this. Maybe not something you can share widely, maybe with just a few people, but a sense that I've been there and done that too, right? Like that sense of community.
Well, listen, I assure you that once our social media reels from this conversation go out there, we're going to viralize you so much. You're going to have multi-billion views.
Well,
and if you're a little bit surprised that you haven't had any invites, get ready. Get ready for Rogan. I'm going to manifest Joe Rogan. You should be at Rogan. I'm not joking.
No, not joking, for sure.
I manifest that because people need to listen to you. And we are just a small pedestal to the world, but there are others that have a bigger one, and I hope and manifest and I activate for you, because the world deserves to hear more of you, and I can't wait to applaud your continuing journey in this.
Yeah, and for the next study, whenever it comes out or preview to it, just let us know.
Yeah, don't forget that we were the first ones to give you a shot, okay, bro? All right, don't be like, go back when you're like on your gen and all that. Like, come back to the little guys, okay? Come back to the plumbers of vascular surgery and show us the way, okay? All right.
Yeah. Yeah, I don't want to jet. I want to find a way to keep doing this work in a legal, responsible way.
Awesome.
But thank you so much for that. I appreciate your good wishes and good energy and manifesting what's going to be next.
There you go.
Thank you so much.
As we say in my country, pura vida. So pure life and
Yeah.
be well.
You too. Okay. Bye-bye. Thank you.